Okay, so I also just realized I have to go over hypovolemic shock, anaphylactic shock. So I'll go over anaphylactic, hypovolemic. I'm gonna go over heparin. I'm just gonna get it done with, and then I'm just gonna really quickly talk about DIC. I can't remember if I went over it already, but I feel like it just helps to see it with heparin induced and make sure you understand the differences there. I think I already did go over it, but regardless, I'll just do it again really quickly because again, I just want you to kind of understand those things. So let's talk about hypovolemic shock and anaphylactic shock really quickly. For the patho shock stages, I'm gonna have you guys read that. I didn't even. I think I just read it and it was like really helpful, but I think you don't necessarily have to understand like those differences for. Well, you should understand it, but you don't have to memorize it or like absolutely know it like the back of your hand. But I do think you should know like there's initiation starting at the compensation phase where you're kind of starting to your body's starting to compensate for those effects that you're seeing, and then progressive. Well, it's progressing a little bit more in the refractory, kind of what's happening in terms of the failures, the ischemia, everything. So initiation, less volume, less perfusion, hypoxia of the tissues. Now in your metabolic acidosis state. Compensation, so CNS activation. So that's where you see the heart rate being, compensating to get the cardiac output better. Endocrine responses with like increased blood volume, vascular resistance, water retention, catecholamines, compensations, respiratory rate to blow off of CO2, things like that. Progressive, well, now you're hypoperfusing, so increased, inadequate tissue perfusion, less cell function, anaerobic metabolisms. So again, you're having that production of lactic acid happening, decreased BP because of the volume. It's kind of, I think about it like how we talk about with like early versus late sepsis, right? Like cardiac output is high at the beginning, and then eventually it's going to lead to going lower. Because again, it's more about the compensation than it progresses into worsening dysfunction. And in terms of refractory, now you're having hypoxemia, ischemia, failures of those different things. The hypotension being persistent, kind of also like with septic shock, right? Like, same thing. You have maybe an okay blood pressure, and now it's going to be a lot lower. So hypovolemic shock, obviously the blood volume, so hypovolemia, right? Blood volume is not adequate to fill the intravascular system. So with that, the problem is that means that that's not being traveled. I think you just have to think about AMP. Like, what's the important part of having your blood there? So that's perfusing the rest of your organs and everything, right? So inadequate blood, and then no oxygenation or perfusion to the rest of the organs and to the tissues. That can lead to a lot of ischemia. That can lead to less oxygenation perfusion overall, and then you have things like your organs are basically going to start giving up, right? So the causes of that, well, we know the biggest one is blood loss, so obviously bleeding or any type of trauma going on. So obviously most seen in hemorrhages, or you're diuresing the patient so much to their obviously like their volume overall, like their CVP volume is just low, right? So again, surgeries, traumas, OB is a big one with like postpartum hemorrhages and also just losing a lot of blood in general. DIC, GI bleeds, big one, organ rupture, hemothorax, things that you see there. Usually, again, all blood, volume related. Manifestations, hypotension, obviously, because that's the whole point of hypovolemia. Tachycardia, because now, again, with that progressive stage and that compensation stage, you're having the compensation of your heart rate trying to increase to get the cardiac output to get out there. Because, again, heart rate times stroke volume, what's going out to the rest of your body, the blood going to the rest of the body, and your heart rate having to pump that out to the rest of the body as much as it can or as fast as it can. So your heart rate's compensating for that. So again, oliguria, because again, at this point, do you even have volume, right? Low H&H, right, with the blood loss. And then also keep in mind, you could also have a high H&H, and we talk about the hemoconcentration as well with fluid loss. Because you have less volume, but at the same time you have a higher amount of, and we'll talk about that kind of like with DI and SIADH, like the differences within that. Kind of is similar in terms of you have a high H&H hemoconcentration because you have less volume overall, so that leads to having a higher concentration because of that H&H just being there. In terms of low cardiac output, cardiac index just being that body surface area, keeping in mind to the cardiac output, right? So basically low cardiac output because again you don't have that much volume. And so same thing with CVP and PCWP. Those are the same things. Those are talking about your volume statuses, right? So the pulmonary wedge pressure, and then your central venous pressure as well. So low, everything except for your heart rate, because your heart rate's trying to compensate for that perfusion state and that cardiac output. So in terms of treating the underlying cause, well, what can you do to help with those things? You could give a bolus, right? Or you could give them those isotonic fluids to help with their volume overall, right? So those crystalloids, so normal saline, same thing, what we've always talked about, right? So normal saline. And then when we talk about these other things, there's like a couple of them that are only hypertonic saline, right? Um, we'll talk about that later, but at least for the fluid resuscitation, normal saline, or you can do LR, which is another one. But again, the reason why we kind of want to caution with that, which is a little bit different of what we learned in like third semester, like with sepsis, I think we learned with LR, just because again, the liver can change that into bicarb. But the problem is that you don't know the patient's liver function. Sometimes when they're coming in, you have to grab their labs and look at their LFTs, get their history, all these different things. So just to be safe, the first one you should always do is normal saline. You could also give albumin, and that's colloids, just to help with your overall fluid volume in that space, right? That's going to help with that. And then again, you could give packed cells as well, and that's just a volume expander. So those are the differences there. And that's literally all you have to know. Management, you look at every single thing, your I's and O's, the volume loss, the cardiac rhythm, because you lost a lot of, what's going on. And so H and H, electrolytes, BUN, so with the diuresis and stuff. But it all makes sense. I feel like this is all like super easy, straightforward things. Fluid volume status is the outcome criteria, what we're looking at, I's and O's, weights. BP for organ perfusion, obviously looking at their pulses, cap refill, neuro, what is their baseline of what their A&O status, and then tissue oxygenation overall. Anaphylactic, the differences between that is basically the types of distributive shock allergic reactions. We all know it. Having an extreme immune reaction is basically what we're talking about, an antibody reaction. So basically, the causes, every single thing that we've talked about before, in terms of allergies, we all know this. So like peanuts or just nuts in general, bees and insect bites, medications that people are allergic to, latex allergies, that have, a lot of people, like a lot of healthcare workers, can become very allergic to latex, or I think an NCLEX question I got was like hairdressers. But basically, like patho-wise, the initial exposures, so the immune system produces the hemoglobin E, so the IgE, we talked about that before. Those antibodies are specific to allergens, right? And they bind to mast cells and basophils. Again, those are also specific to your allergic reactions. So basically, after that exposure, your later subsequent exposures, the allergen attaches to the IgE antibodies, and they trigger mast cell degranulation. So this releases mediators like histamine, widespread vasodilation, and increased vascular permeability, kind of like what we talked about earlier or before with sepsis. But basically, this leads to the hypotension, the fluid leaking in the tissue, similar to that autoimmune reaction of what's going on in sepsis. But basically, you have that increased vascular permeability and capillary permeability. All of that fluid kind of leaks out. And because of that, also at the same time, that histamine being produced leads to the bronchoconstriction, and that's what also leads to the respiratory distress. So not only are you having like hypotension with all of those things, but you're also having bronchoconstriction because of all the histamine being released and having the effect on that. And so that's why you see the shortness of breath and the wheezing with anaphylactic shock. So this symptom can obviously kill a patient, right? And that can escalate very rapidly. So that's also why you can see signs and symptoms for like the histamine releases with like hives and with like angioedema. And then GI symptoms, severe hypotension. So basically, it could lead to organ dysfunction overall, and you're not breathing anymore, you're not being perfused. So definitely both of these things are emergency things, that you critical care things, but basically the summary of what you're seeing is, again, the increased capillary permeability leads to all this fluid shifting to go out. Now you have hypotension, and now you're not being properly perfused. And then additionally, because of the histamine release and all of those increased things and side effects that we're seeing with like periorbital edema, airway compromise, respiratory impairment, and hypotension. And remember, with at least periorbital edema, that's specific to anaphylactic shock here, what we're talking about. So you can look at all the manifestations. I feel like it's every single thing you kind of know about allergic reactions, so I feel like that makes sense. Management, you call 911 immediately, and then with any doubt, you administer epinephrine, so you may need to repeat that. So if you are in a hospital setting, it's important you cannot just give epinephrine if you know that the patient is having an allergic reaction, you still need an order. So if that's the case, you can call a rapid or you can call a code blue. But one thing to kind of know is just again, you need an order to do this. Um, and those are the cases there. So you can't just administer it because you feel like it. It's time to do one of those things to make sure you can get that provider and those other people in there, and then you can go about it that way. But you can't just give it, even if you do know it, which I get can be a little bit frustrating. But again, in this case, you're going to need a whole team in there to help you out with the rest of the stuff, anyways, and you still need people to help you reassess because you give. Let's say you give epinephrine, right? That's a great thing, great. They'll but they still could have a lot of airway compromise. And also, we don't know how severe the effect is going to be. They could still have like impairments neurologically, respiratory wise. There's a lot of things, right? So hypotension, basically, you give IV fluids for that. Airway, you have the like albuterol, which is the short acting adrenergic agonists, right, that we've talked about. And I feel like that makes sense because you see people with like the inhalers, and then same thing for the long acting salmeterol, and then O2, obviously, airway intubation and ventilation if they really do need it because of the risks there. Anti-inflammatories, antihistamines, because the whole entire point is we're having like the histamine response be crazy. And so there's different types, right? So you can give diphenhydramine and then famotidine, and then steroids wise to also help with the inflammation response, you can give your steroids there. And then education, don't try to go to those things that are triggering you. If you're allergic to nuts, don't eat them. Educate on epinephrine use. You can jab it with your or without your clothes on, and the lateral thigh is probably the easiest. And remember those differences between the orange and the blue, and your blue goes to the sky. So call 911 if they need it. You raise the feet. That helps. Raising their feet also helps with like the blood pressure and what's going on um, with the hypotension. In terms of keeping epi, you should do that. Like keep it on you, keep it in places that you might need it. And if you usually use it frequent, keep it on you. Educate your family and friends to also be aware of how to use it and what are the signs and symptoms that you get from these allergic reactions. And then also like you can see frequently like how your allergic reactions are with skin testing and seeing if it's something where you're going to have a life-threatening reaction or not, right? So DIC, talking about that, I think I did go over, I really can't remember. Secondary to sepsis, basically consumption of clotting and platelets. So basically you're having coag, and this is also caused, obviously through excess clotting and you're having bleeding. So basically what's going to happen is that tissue damage, vessel damage, and infections are usually the causes. So uncontrolled hemorrhage, and then basically microclots and small vessels that are also, it's two like things in one, which it's like, you got to be kidding me. So bleeding and then excessive clotting with all these little microclots that then are obstructing your blood flow and your vasculature. So that leads to organ perfusion being impaired and tissue ischemia basically happening. And then again, because of the consumption of what's happening to your clotting factors and platelets, you're also having that uncontrolled bleeding as well. And then the diagnostics there increase PTINR, PTT, D-dimer, thrombin, FDP, and FSP. So those are the fibrin degrading products because, again, fibrin is broken down. And so decreased platelets, H&H, fibrinogen. So if I were you, memorize or just know that those three are decreased, right? And then the rest are increased. And that's all you have to know. And then basically the underlying cause will stop massive coagulation by administering heparin and antithrombin 3. So you can give those medications, which is different than HIT because with HIT, that's heparin-induced thrombocytopenia. So you don't want to give heparin, right? So those are the two differences. Do not give heparin if one of them has heparin induced in it. So don't give heparin for HIT. And then obviously controlled bleeding, replace blood products, and then platelets are usually the first line for that. So yeah, don't get this confused. But going into at least HIT, I'm like, where is it? Yeah. So going into this, basically an immune response to heparin where there's a decrease in above or equal to 50% of highest platelet count after heparin is started, basically. So the heparin, we know that's an anticoagulant, so it can help prevent clots, and it acts on those clotting factors, but it's not their platelets, right? So don't get that confused. So obviously, platelets still play a role in clotting, but specifically with HIT, it's just an immune response of what's happening in the body to heparin, and so that basically, paradoxically, and this is what it says on here, activates platelets and causes clots, even though heparin is meant to be an anticoagulant, which is really interesting. So it usually happens within 5 to 10 days of starting this, but it can also have a rapid onset within a couple of hours. So with heparin-induced thrombocytopenia, basically there's a higher risk of unfractioned heparin, so UFH, compared to low molecular weight heparin. So basically to kind of explain this, because I just wanted to like put this in there to kind of understand some stuff. I don't think you have to know this, but basically unfractioned heparin, it has a larger molecular structure compared to your low molecular weight heparin, and it's literally in the name, right? But the larger size allows this to bind to PF4 more readily and in multiple locations, so it makes it easier for the immune system to form antibodies against the heparin PF4 complex. And why do you have to know this? Well, we'll talk about the patho here in a second. But basically, with HIT, it's an immune mediated adverse reaction to heparin. So when heparin binds to a protein, it binds to that protein called platelet factor 4. So it's PF4, right? So it's a small protein released by platelets during the process of clotting. So basically, what's happening, immune response, heparin binds to that protein, and so it produces the antigen complex on the platelet surface. So basically, how it does this is in small parentheses. I'm still going to read it because it's interesting. PF4 is positively charged, while heparin is negatively charged, allowing them to form that complex. They go on the platelet surface. They form what's called an antigenic complex, and that's basically something the immune system sees as foreign. So they make that complex, the body sees it as foreign, and the body's immune system basically recognizes this complex as foreign and produces antibodies against it, and that's where you see the IgG response, right? So basically your splenic macrophages basically remove the platelets, which causes the count to decrease because they know that this thing is foreign. So at least for talking about earlier, the larger size, basically compared to the low molecular weight heparin, basically UFH can bind to PF4 more readily and in multiple locations, so that makes it easier for the immune system to make those antibodies against that heparin PF4 complex. So that's kind of talking about those things, and you might have to read it a couple of times to understand it, but essentially what's happening with this is that immune response, your body basically binds to, the heparin binds the protein PF4. It produces an antigen complex on it. Your body sees it as foreign. Macrophages are formed and starts to basically taking away all of your platelets because it sees it as foreign. So your body's trying to protect you, but really it's confused. So with results, basically with platelets removed in the spleen and the already short life of platelets, which is like 7 to 10 days, now you have thrombocytopenia. And so obviously, if you have low platelets, you have to be worried about your bleeding risk and also the hypercoagulability effects after. So manifestations, as platelets are activated and consumed, you can have a main problem of thrombosis, of clot formation. And that is despite a low platelet count, but it's kind of, again, thinking about like the compensation response, not compensation response. I don't really like that term for this at least, but it's more of, again, you're seeing all of these things with the hypercoagulability because, again, your body's going to try to make a lot of these things, these clots as well, to decrease from the bleeding risk of what's happening. So risk of thrombosis because of the clot formation. So this causes both venous and arterial clots, leading to complications like a DVT, PE, MI, a CVA, obviously, and then altered organ dysfunction. Because again, if there's a clot, no perfusion, then you will see bleeding as a secondary effect. So again, knowing the difference between this and DIC. This could also cause DIC within that. And in terms of the management, are we going to give heparin? Well, it's heparin induced, so no. You're going to stop all heparin. So you just have to remember, obviously, if it has heparin induced, you're not going to be giving heparin. It's going to the other one you're giving heparin for, right? So stop all heparin products and anticoagulants because, again, heparin is still an anticoagulant. Who knows if these other factors can also have the same response? So that includes the warfarin and enoxaparin, heparin flushes, heparin-coated catheters, because sometimes you have to flush those central lines with heparin or all these different things. Um, and so platelets should be avoided. That depends on the counts, but remember that they are having platelets being attacked. So this leads to thrombocytopenia and further hypercoagulability. So again, platelets for the most part should be avoided because it's just going to keep creating this process of what's happening. And then also, can we do for the labs? Well, you can look at the PF4. So I think that's a beautiful thing. I love it when labs just are straight up like this, where it's like, okay, PF4, that's what we talked about within the patho. So you can look at the PF4 heparin antibody test. Other labs, obviously, looking at their H and H, seeing if they're having that bleeding risk of what's going on. Do they have an active bleed? Their platelets, obviously, BUN and creatinine, LFTs, ABGs. Again, that's having to deal with, is there any clots affecting our kidneys, our hepatic organ, and then additionally, if we're having any pulmonary embolisms, DVTs, anything like that. And so the nurse should follow the platelet count and trend in all patients receiving anticoagulants anyways. But again, that includes those heparin products, warfarin products, and if there's a heparin-coated catheter inserted as well. The medications for this, basically, again, also education on bleeding. We talked about this before with like brushing your teeth, razors, all those things. Same thing as before. Treatment, medications, the two medications you do have to know. And again, everything in green you should kind of keep in mind, like you should be knowing these things. Two agents labeled for use for HIT. Argatroban, and then I can't say the last one, but lepridin. So both are basically direct thrombin inhibitors, which basically, again, thrombin plays a factor in the clotting process. So it converts the fibrinogen to fibrin that's necessary for the structure to clot and to make that structure. And additionally, the argatroban is basically used more, and then that's just because the other med is kind of has more risks of antibody formation and it has an increased half-life. But for the most part, you just have to memorize these two meds, understand that they're antithrombin or direct thrombin inhibitors, and basically help to play a factor within that clotting process. And then other thrombotic agents are those two right there. So I kind of just memorize it as, I just memorize like almost like their syllables. So I would just write them out, do what you have to do there. But that's pretty much it for heparin, and kind of understanding the differences between that and DIC. Well, you kind of know a little bit more about that now. But they kind of have similar manifestations in terms of like you have that thrombotic risk and then you also have the bleeding as well. But also to keep in mind with those things, with DIC, you also have the excessive clotting, significant bleeding, and you can see those differences, at least with the management. Obviously, you wouldn't want to give a heparin-induced thrombocytopenic patient heparin, so keep those things in mind. But other than that, again, those are going over those things there, and then really, other than that, we just have to go over this whole thing here, and then probably just discuss neuro. But yeah, other than that, hope this helps.